Hi, this is Dr. Akhtar Amin and today's topic is thyroid eye disease, also known as TED, thyroid associated orbitopathy, Graves' ophthalmopathy. It's a very common disorder, orbital disorder, the most common cause of both bilateral and unilateral proptosis in an adult. So this is important. It is the most common cause of both bilateral and unilateral proptosis in an adult, and it is an autoimmune inflammatory disorder. Here you can see in the pictures, this is thyroid disease patients. Now, what is the etiology? Thyrotoxicosis or hyperthyroidism. It is a condition involving excessive secretion of thyroid hormones. Graves' disease, it is the most common form of hyperthyroidism. It is an autoimmune disorder. In this disorder, IgG antibodies bind to thyroid stimulating hormone receptors in the thyroid gland and stimulate secretion of thyroid hormones. It is more common in females and may be associated with other autoimmune disorders. Presentation is often in the 4th or 5th decades with symptoms including weight loss, bowel frequency. So there is weight loss, bowel frequency, and the weight loss is despite good appetite. And increased bowel frequency, there is sweating, heat intolerance, nervousness, irritability, palpitations, weakness and fatigue. Enlargement of the thyroid gland, there are tremors, and there is sinus tachycardia and other arrhythmias. There is palmareithema and warm and sweaty skin and pretibial myxedema. So there may be enlargement of the thyroid gland and there is thyroid acropathy. It is a phenomenon similar to clubbing of the fingers occurring in 1% of the patients. The pretibial myxedema occurs in 1 to 5%. And what is pretibial myxedema? It is indurated thickening of the skin of the shins. Cardiac manifestations may include sinus tachycardia and other arrhythmias. Other autoimmune disorders can be associated. Thyroid function is commonly tested initially with a TSH level. If the TSH level comes to be low, our investigations can be normal. If it comes to be low or normal, but thyroid disease is still suspected, then you can do a range of other additional investigations. The treatment options include carbimazole, propylthiouracil, propranolol, thyroid ablation with radioactive iodine, and partial thyroidectomy. What are the risk factors for ophthalmopathy in patients of hyperthyroidism? Once a patient has Graves' disease, the major clinical risk factor for developing thyroid eye disease is smoking. So number 1, smoking. The greater the number of cigarettes smoked per day, the greater the risk, and giving up smoking seems to reduce the risk. Next is the gender. Women are 5 times more likely to be affected by TED than men, but this largely reflects the increased incidence of Graves' disease in women. Another risk factor is radioactive iodine. The radioactive iodine, it is used for what? It is used to treat hyperthyroidism. It can worsen TED. This condition can also, though less commonly, occur in euthyroid and hypothyroid, including also the treated hyperthyroid patients. It can sometimes be the presenting manifestation of thyroid-related disease. Low selenium levels and stress is also risk factors. Now the pathogenesis of ophthalmopathy. What occurs in thyroid ophthalmopathy? There is organ-specific autoimmune reaction. In this reaction, there is antibody. That antibody reacts against thyroid gland cells and orbital fibroblasts. and that leads to inflammation. Inflammation of what? Inflammation of extraocular muscles. Also the interstitial tissues and the orbital fat and the lacrimal glands. So there is organ-specific autoimmune reaction. The antibody reacts against thyroid gland cells. So what happens further? There is pleomorphic cellular infiltration associated with increased secretion of glycose aminoglycans and osmotic imbibition of water. So there is an increase in the volume of orbital contents. So there is an increase in the volume of orbital contents in the muscles. About 8 times it can swell. Particularly the muscles increase in volume occur and up to swell up to 8 times their normal size. There may be a secondary elevation of intraocular pressure, and the optic nerve may be compressed. Subsequent degeneration of muscle fibers can occur, and it can lead eventually to fibrosis, and that's fibrosis exerts a tethering effect on the involved muscle, and it can result in restrictive myopathy and diplopia. Clinical features occur in 90% patients are hyperthyroid and 60% present within 1 year of thyroid disease, while 40% in more than 1 year of thyroid eye disease. In thyroid disease, there is active phase and stable phase. In active phase, you can see there is congestion, inflammation, and the eyes are red and painful. This tends to remit within 1 to 3 years. 1 to 3 years. 1 year in non-smoker, 2 to 3 years in smokers. 10% of patients develop serious long-term ocular problems. Then there is stable phase, fibrotic stage, fibrotic or quiescent stage, and this stage follows in which the eyes are white, although a painless motility defect may be present. The clinical features broadly can be categorized into soft tissue involvement, lid retraction, proptosis, optic neuropathy, and restricted myopathy. So these 5 are the mainly problems in thyroid eye disease: soft tissue involvement, lid retraction, proptosis, optic neuropathy, and restrictive myopathy. A commonly used classification for the severity of thyroid eye disease has been issued by the European Group of Graves Orbitopathy. European Group of Graves Orbitopathy (UGOGO) classification, in which the first stage is sight-threatening, and sight-threatening due to optic neuropathy and corneal breakdown. The second group is moderate to severe, in which there is one of moderate to severe soft tissue involvement, lid retraction of 2 mm or more, diplopia, and proptosis of 3 mm or more. So moderate to severe, there is lid retraction, soft tissue involvement, and proptosis. And third is mild group, in which there is only a minor impact on daily life. So number 1 clinical feature is soft tissue involvement. The symptoms are grittiness, red eyes. Here you can see there is lacrimation, photophobia, and puffy lids. You can see the puffy lids and retrobulbar discomfort. The signs include epibulbar hyperemia. You can see there is epibulbar hyperemia. This is a sensitive sign of inflammatory activity, and intense focal hyperemia may outline the insertion of horizontal recti. There is periorbital swelling. Periorbital swelling is caused by edema and infiltration behind the orbital septum. This may be associated with chemosis and prolapse of retroseptal fat in the eyelids. Retroseptal fat in the eyelids. Tear insufficiency and instability is common. The corneal signs are exacerbated by lid retraction, and the signs are punctate epithelial erosions, superior limbic keratoconjunctivitis, occasionally bacterial keratitis, thinning, and scarring. Second most important sign is lid retraction. The retraction of the upper and lower lid occurs in about 50% of patients with Graves' disease. Now the mechanism is suspected that there is overaction of mullar muscle and to occur as a result of sympathetic overstimulation and secondary to high levels of thyroid hormones. There may also be fibrotic. The lid retraction is also due to fibrotic contracture of the levator palpebrae superioris muscle and the fibrotic contracture of inferior rectus muscle, and this is associated with adhesion of overlying orbital tissues. So this is another probable mechanism, together with secondary overaction in response to hypo or hypertropia produced by fibrosis. Now the symptoms of this lid retraction: the patient complains of staring or bulging eye appearance, difficulty closing the eyes, and ocular symptoms. Signs. The first sign is scleral show. What is scleral show? Normally the upper lid margin normally rests 2 mm. Here you can see 2 mm below the limbus. Lid retraction is suspected when the margin is either at the level of the limbus or when the lid margin is above the superior limbus, which allows the sclera to be visible. This is called scleral show. The Dalrymple sign. The Dalrymple sign is lid retraction in the primary gaze. The lower lid retraction may also occur in isolation or association with proptosis. The proptosis exaggerates the lower lid retraction. Inner sign is Kocher sign. It describes a staining or frightened appearance of the eyes. It is particularly marked on attentive fixation. Here you can see Kocher sign. Inner is Von Graefe sign. Von Graefe sign signifies a retarded descent of the upper lid on down gaze. This is known as lid lag. Here you can see the left eye is normally looking down while the right cannot look down. Lid lag. Next important thing is proptosis. Proptosis symptoms are similar to those of lid retraction, like staring, bulging eye appearance, difficulty closing the eyelids, and ocular surface symptoms. The signs: the proptosis may be axial, may be unilateral or bilateral, and frequently permanent. Here you can see symmetrical proptosis, and here you can see asymmetrical proptosis. If there is severe proptosis, it may compromise lid closure, and along with lid retraction and tear dysfunction, it can lead to exposure keratopathy, corneal ulcers, and infection. Another important sign is restrictive myopathy, which occurs in between 30 to 50% of patients with TED, and this may be permanent. Ocular motility is restricted initially by inflammatory edema and later by fibrosis. Symptoms: there may be double vision and often discomfort in some positions of gaze. Signs occur in order of frequency. Initially, in restrictive myopathy, there is elevation defect. Elevation defect is caused by fibrotic contracture of the inferior rectus. So when the inferior rectus there is fibrotic contracture. It may mimic superior rectus palsy. There is elevation defect, so it may mimic superior rectus palsy, and it is the most common motility defect. Elevation defect is here you can see defective. In the left eye you can see here the elevation defect. The elevation defect is the most common motility defect. After elevation defect, the second most common is abduction defect, occur due to fibrosis of the medial rectus. It may simulate sixth nerve palsy. Depression defect, here you can see in the right eye there is depression defect secondary to fibrosis of the superior rectus, and the last is adduction defect caused by fibrosis of the lateral rectus. So the most important here is elevation defect, the most common. Optic neuropathy is a fairly common, up to 6%. It is a serious complication caused by compression of the optic nerve or its blood supply at the orbital apex by congested and enlarged recti and swollen orbital tissues. Here you can see compression of the optic nerve and its blood supply at the orbital apex and by congested and enlarged recti and swollen orbital tissues. Such compression, which may occur in the absence of significant proptosis, it may lead to severe visual impairment if adequate and timely treatment is not instituted. So in thyroid eye disease, compression of the optic nerve secondary to enlarged and congested rectus muscles may occur in the absence of proptosis. So keep in mind that point. The symptoms are: there may be impairment of central vision occurs in conjunction with other symptoms of TED. In order to detect early involvement, patients should be advised to monitor their own visual function by alternatively occluding each eye, reading small print, and assessing the intensity of colors, for example on a television screen. So this is important. Signs: a high index of suspicion should be maintained for optic neuropathy, and it's important not to mistakenly attribute disproportionate visual loss to minor disease. Visual acuity is usually reduced but not invariably. Color desaturation is a sensitive feature. So colors desaturation important. There may be diminished light brightness appreciation. A relative apparent pupillary defect (RAPD) if present should give cause for marked concern. Visual field defects can be central, paracentral, may be combined with nerve fiber bundle defects. These findings in concern with elevated intraocular pressure may be confused with primary open-angle glaucoma. The optic disc may be normal, optic disc may be swollen, or rarely atrophic. Now the investigations. The investigations other than blood tests for thyroid disease are not necessary if the diagnosis is evident clinically, but the exclusion of other conditions is sometimes indicated. Visual field testing is carried out if there is a suspicion of optic nerve compromise, or may be performed as part of the baseline evaluation, even if there is no apparent visual impairment. MRI, CT scan, ultrasonographic imaging of the orbits, they are indicated in some circumstances, such as helping to confirm an equivocal diagnosis by identification of the typical patterns of extraocular muscle involvement in thyroid eye disease, consisting of muscle belly enlargement with tendon sparing. Here you can see muscle belly enlargement with tendon sparing. Imaging is also used in the assessment of optic nerve compression, and prior to orbital wall surgery, visual evoked potential are sometimes utilized in optic neuropathy. For diagnosis, two of the following three are necessary. Number one is concurrent recently treated immune-related thyroid dysfunction and thyroid antibodies. Typical ocular signs such as compressive optic neuropathy, fluctuating eyelid edema, erythema. Here you can see bilateral chemosis, conjunctival injection, caruncular edema, restrictive strabismus causing marked esotropia in a patient with relative enlargement of the right medial rectus muscle. Here is bilateral upper and lower eyelid retraction, proptosis, lateral flare, left relative X ophthalmos you can see. The third is radiographic evidence of thyroid eye disease, which you can see in this axial orbital CT scan. It shows characteristic fusiform enlargement of extraocular muscle in yellow, and that spares the tendons. Here you can see coronal orbital CT scan shows bilateral enlargement of extraocular muscle, bilateral enlargement. Now treatment. Treatment can be classified into that of mild disease. Most of the patients have mild disease, moderate to severe active disease, and treatment of post-inflammatory complications. The first measure taken in all cases should be cessation of smoking. Thyroid dysfunction should also be managed adequately. A radioiodine treatment is administered in patients with pre-existing thyroid eye disease. A short course of oral steroid should be given in concert. So, short course of oral steroids. Now, when a patient comes with mild disease, most patients have mild disease, so give lubricants for superior limbic keratoconjunctivitis, corneal exposure for dryness, topical anti-inflammatory agents such as steroids, non-steroidal anti-inflammatory drugs, cyclosporine are advocated for by some authorities. Head elevation with 3 pillows during sleep to reduce periorbital edema. And eyelid taping during sleep may alleviate mild exposure keratopathy. Eyelid taping. So these are for the mild disease. Head elevation, eyelid taping, anti-inflammatory and lubricants. Now moderate to severe disease. For that we use UGOGO score, clinical activity score. It suggests calculating a clinical activity score, aid in determining a threshold for the use of immunosuppressors. In this score we assign 1 point for each feature present from the following list. In considering treatment for a score of 3 or more out of 7. So what are the points? The one is spontaneous orbital pain and gaze evoked orbital pain. Eyelid swelling. Eyelid swelling considered to be due to active inflammatory phase. Eyelid erythema and eyelid swelling, eyelid erythema, conjunctival swelling, conjunctival redness, conjunctival redness considered to be due to active inflammation, and chemosis, and last one is inflammation of caruncle or plica. Then during subsequent review, then point is allocated for an increase in proptosis of 2 mm or more. So proptosis is measured and then again in subsequent review it is measured. A decrease in uniocular excursion in any one direction of 8 degree or more, and a decrease in Snellen acuity of one line. So 1 point is given into each of these points. Systemic steroids are the mainstay of treatment for moderate to severe disease. Oral prednisolone 60 to 80 mg per day may be given initially and tapered depending on the response. Intravenous methylprednisolone. Intravenous methylprednisolone is often reserved for acute compressive optic neuropathy, but tolerability is better and outcomes may be superior compared with oral treatment. A lower intensity regimen in the absence of acute sight-threatening diseases 0.5 gram once weekly for 6 weeks, followed by 0.25 gram once weekly for 6 weeks. A reduction in discomfort, chemosis and periorbital edema, it usually occurs within 24 hours with a maximal response within 2 to 8 weeks. Ideally, oral steroid therapy should be discontinued after several months, but long-term low-dose maintenance may be necessary. Orbital steroid injections are occasionally used in selected cases to minimize side effects, but are typically considered less effective than systemic treatment. Low-dose fractionated radiotherapy may be used in addition to steroids or when steroids are contraindicated or ineffective. But because of the delayed effect, it is not used as a sole treatment of acute optic nerve compression. Positive response is usually evident within 6 weeks, with maximal improvement by 4 months. Around 40% will not respond. Adverse effects include cataract, radiation, retinopathy, optic neuropathy, and increased risk of local cancer. Threshold for its use should be higher in younger patients and diabetes, because in diabetes there is possible increased risk of retinopathy. Combined therapy with eye radiation, azathioprine, low-dose prednisolone may be more effective than steroid or radiotherapy alone. So combine therapy with eye radiation and azathioprine and low dose prednisolone. Immunosuppression in the active inflammatory phase of thyroid eye disease is important to reduce acute inflammation and to prevent long-term complications. For optic neuropathy and less commonly intractable corneal exposure, it requires aggressive treatment, and that is pulsed intravenous methylprednisolone. The regimen includes 0.5 to 1 gram on 3 successive days with conversion to oral treatment 40 mg per day prednisolone, or 0.5 to 1 gram on alternative days 3 to 6 times, keeping the maximum dose below 8 gram to reduce the risk of liver compromise, followed by oral prednisolone. Appropriate monitoring should be instituted, including liver function test as well as gastric protective treatment and osteoporosis prophylaxis if necessary. Orbital wall decompression and or orbital apex decompression may be considered if steroid are ineffective. 20% receiving intravenous treatment, these are ineffective. Steroid are ineffective, or when steroid are contraindicated. Orbital radiotherapy may also be administered, but is generally only used in adjunct to other modality. Several drugs targeting specific aspect of the immune response in thyroid eye disease are under investigation, notably monoclonal antibody treatment with the rituximab and teprotumumab. Teprotumumab is an inhibitor of the insulin-like growth factor 1 receptor IGF-1R, effective in reducing proptosis and the clinical activity score in patients with TET. Post-inflammatory complications. Eyelid surgery should be performed only after any necessary orbital and then strabismus procedures have been undertaken. So eyelid surgery should be performed after these surgeries, because as orbital decompression may impact both ocular motility and eyelid position. So orbital decompression may occur initially, should be done initially. And extraocular muscle surgery may affect eyelid position. So extraocular muscle surgery should be done before eyelid surgery. Surgical orbital decompression should be considered when there is sight-threatening compressive optic neuropathy in thyroid eye disease. For proptosis, after active inflammation has remitted, the patient can be left with cosmetically and functionally significant proptosis, the treatment of which is essentially surgical. Surgical decompression increases the volume of the orbit by removing the bony walls and may be combined with removal of the orbital fat. Most surgery is undertaken via external approach, though the medial wall and the medial part of the floor can be reached endoscopically. One wall deep lateral decompression is effective, approximately 4 to 5 mm reduction in proptosis. So deep lateral can cause 4 to 5 mm reduction and may reduce the risk of post-operative diplopia. Two wall, the balance medial and lateral decompression. It provides a greater effect but with a significant risk of inducing diplopia. Three wall decompression. It includes the floor with a reduction in proptosis of 6 to 10 mm but may lead to hypoglobus or carries a higher risk of infraorbital nerve damage and diplopia. Very severe proptosis may require removal of part of the orbital roof. In addition, four wall decompression. Restrictive myopathy. Surgery is required in most cases. Experiences permanent persistent diplopia in the primary or reading position of gaze, providing the inflammatory stage has been subsided and the angle of deviation has been stable for at least 6 to 12 months. Until these criteria are met, diplopia may be elevated, if possible with prisms or sometimes botulinum toxin. The goal of operative treatment is to achieve binocular single vision in the primary and reading position. Restrictive myopathy often precludes binocularity in all positions of gaze. Although with time the field of binocular single vision may enlarge as a result of increasing fusional versions. Recession of the inferior or medial recti is the most commonly indicated surgery. Recession of inferior or medial recti, inferior rectus and medial rectus. Rectus muscle is never resected. Keep in mind, rectus muscle is never resected, only recessed in thyroid eye disease, generally utilizing adjustable sutures. Suture is adjusted later in the same day or on the first post-operative day to achieve optimal alignment, and the patient is encouraged subsequently to practice achieving single vision with a consistently accessible target such as television. Lid retraction is another complication. Mild lid retraction frequently improves spontaneously, so does not require treatment. Control of hyperthyroidism may be beneficial. Botulinum toxin injection to the levator epineuritis and Mueller muscle may be used as a temporary measure in patient awaiting definitive correction. So this is treatment for lid retraction, botulinum toxin into levator epineuritis. Muellerotomy. Muellerotomy, disinsertion of Mueller muscle, is effective for mild lid retraction, but more severe cases may also require recession, disinsertion of levator epineuritis and suspensory ligaments of the superior conjunctival fornix. Suspensory ligaments. Recession of the lower lid retractors with or without hard plate graft can be used. With or without hard plate graft can be used when the retraction of the lower lid is 2 mm or more. Thank you very much. One thing which we left are the differential diagnosis. These are also important because this is a lot of other diseases can mimic TED, like allergic enteritis. There is tearing, acute in onset from a new exposure. It causes itching. There is no lid lag. Myasthenia gravis. There is diplopia. It improves after rest, and there is ptosis. Orbital myositis. There is enlargement and inflammation of the muscle body and tendon also. There is also no retraction. It is unilateral. Orbital tumors is unilateral and that wide variety of motility disturbance, no lid lag or retraction. Carotid cavernous fistula, there is tinnitus, pulsatile exophthalmos, not cause eyelid retraction or temporal flare. Chronic progressive external ophthalmoplegia is progressive over 5 to 15 years, and there is ptosis and down gaze most likely spared. Inflammatory orbitopathy such as granulomatosis with polyangiitis, a mix of upper airway, lower airway and renal pathologies, IgG4 disease by biliary tree involvement, retroperitoneum involvement and salivary glands. Thank you very much for your time. Please like and subscribe and share.